All right, since it's about 7:30, we'll go ahead and get started. My name is Mitchell Kronenberg. I'm the Director of Channel Management for Diagnostics, so that includes Slit Lamps and Slit Lamp Imaging. We'd like to go ahead and introduce our speaker this evening. It is Dr. Paul Karpecki. Thank you again for volunteering to do this. We greatly appreciate it. Dr. Karpecki received his Doctor of Optometry degree from Indiana University and completed a Dury Fellowship in Medical Cornea and Refractive Surgery in Kansas City in affiliation with the Pennsylvania College of Optometry. He currently serves as the Director of Cornea Services for Kentucky Eye Institute in Lexington, Kentucky, Gaddy Eye Centers in Louisville, Kentucky, Center for Sight in Carmel, Indiana. He is the Medical Director of Kepler Vision and on the LBRS team at IOR Partners. In 2017, he completed a full year preceptorship in advanced retinal disease at Retina Associates of Kentucky. He also currently serves as an associate professor at the Kentucky College of Optometry in Pikeville. Dr. Karpecki was appointed to the Delphi International Society, which includes the top 25 dry eye experts in the world. He co-chaired the Dry Eye Summit for the profession, was selected to the TFOS Dues II Diagnostic Methodology Subcommittee, and appointed co-chair for the Tear Film and Ocular Surface Society Symposium. He served as a co-chair of the Dry Eye session at the Ophthalmic Innovations Summit during ASCRS and co-chaired OIS Optometry. Dr. Karpecki also serves as the Chief Medical Editor of Review of Optometry, the host read-journal in the profession, and is on board with the charitable organization Optometry Giving Site. Hopefully I covered everything there.
I'd say I have to get you a shorter bio in the future, but thank you, Mitchell.
Yeah, once again, we want to go ahead. I kind of stepped in as Garrett O'Connell, our VP of Sales and Marketing here at Haag-Streit, having slight technical difficulties with his internet, but he is definitely listening in, and might chime in here at some point if everything comes back online. So without further ado, I'll let you take over, Dr. Karpecki.
Thank you. I appreciate that, and really appreciate the opportunity to get to participate in this. And I don't know, do I have to do, you said share screen, right, Lauren, in order to then have the capabilities to do this. But then it's going to go probably over to my own phone, but I'm going to allow that.
Lauren might be able to control it if you wanted to.
Well, let's see if I can't really advance it from this standpoint, but I do agree when I do share screen, it's going to continue. Let me go ahead and hit that. Let me hit desktop and Zoom. Okay, let's see what we've got. All right, so I'm going to take you through a little bit of this, and it's going to ask, Lauren's going to tell me if I do that, it won't let us record, but I think we may have you just kind of, I'm just going to take over remote and just kind of go through it from that standpoint. I guess you're going to have to share it or make me a co-host.
Let me see here.
In order for that to work today. Perfect.
1 second, Dr. Karpecki.
Thanks, Lauren. That sounds good. First of all, I want to start by thanking, all those who are on. I know we have a big group tonight, and just says a lot about you to, taking time out of a busy schedule, especially with all that's going on, and certainly hope that everyone is safe, their families are well. And but I think you're going to find tonight will be valuable if you practice in the area of dry eye, and also the importance of Haag-Streit imaging and how that applies. And one of the things that Mitchell described when he did the intro, thank you very much, Lauren, was that, the TFOS Dues II Diagnostic Methodology Committee that I was on. And a lot of people, when they get to this point, often feel like it's going to be complex and there's going to be a lot to it. And in actuality, many times, I think as we'll discover, this is a very good way to be able to manage the disease in terms of a practical approach from the standpoint of diagnostics. And we're going to tie that into how Haag-Streit fits into this, because I get the question all the time, even before I go into these first slides, what's the most important piece of equipment you need to start a dry eye clinic? And my dry clinic's large. I have over 500 positive diagnosed Sjogren's syndrome patients, I think 540 on last count or more. Very advanced ocular surface disease cornea practice where everybody's kind of referred in. And so the question comes up a lot, what do I have to have? What's the first piece of equipment? Is it an osmolarity? Is it imaging of meibography? Is it what do I need to have to start a dry eye clinic? And the answer is you need anterior segment imaging. You need the ability to show patients what you're seeing, whether it's expression, corneal staining, breakup time, whatever, so that they understand. It'll save you a lot of time. It'll help them understand the disease, and you'll have something to be able to watch afterwards. So let me go back here a moment again and just kind of talk a little bit about this being the most common disease faced by ophthalmology and optometry. I know we have both professions on the call. Over 90 million people. Now, where that 90 million came from is the fact that it was based on a survey that was done by a big ophthalmic company that looked at how often patients' complaints calling into an optometry and ophthalmology office were related to dry eye. And it was 42% of the time, estimating that to be about 90 million people. Now, if you go into longitudinal studies, the Beaver Dam study, any of these, you'll actually see it's about 30 to 50 million people. Let's put that in perspective. Glaucoma is an important disease to treat, 2.7 million people. We're talking about 30 to 50 million. Now, if you were to look at ophthalmology and optometry ICD codes and say, okay, how much dry eye is actually being diagnosed? It's 17.2 million. This said 16 million. That was 2018 data. 2019 data went up to 17.2. Nevertheless, that's still an underdiagnosis for sure. What's most fascinating is only about 1.6 today, it was 1.5 then, 1.6 million people in 2019 were actually therapeutically treated. Now, we don't have a lot of therapeutics. We have Restasis, Cequa, Clarity C from Imprimis, and Xiidra, of course, from Novartis. That's it. So, but if you took all those together, it'd be 1.6 million out of potentially 90 million. So that tells me that a course like we're doing today is going to be valuable. So this showed that first study, 42% of all comprehensive eye exams involve a complaint, chief secondary related to ocular surface disease. That was the 90 million statistic. Optometry does play a key role in primary diagnosis, but ophthalmology plays a key role in both too. So we really want to encourage the fact that this is just one of the most common diseases to focus on. If you look at the Women's Health Study, I was fascinated by this study because I know it's about 20 years old now, this study, and it kind of makes sense when you look at the data. They didn't even study people under 55. It's like, does dry eye not happen under age 55? And it showed women had twice as much dry eye as men. It showed 14.4% of the population. That's where the 30 to 50 million number comes in. Fortunately, there's been new data since then. And in fact, one of them is the Beaver Dam offspring study, which I'm showing you here. Lead author was Paulson, that showed, if you took the children of that previous study and analyze them, you would find three amazing things. Number one, there's just as much dry eye in the children as there was in the parents. And yes, we're talking 30 years difference on average. And there was just the same statistical amount of dry eye in their children, probably from digital devices, environment. We're not sure, a lot of factors playing a role. Number two, men and women have the same amount of dry eye until you get to the perimenopausal age. Incidence 13% versus 12.3. And number three, it kind of ties into what we talked about. There is progression with age to higher numbers. However, as you look at the overall numbers, that are the same as their adult parents. So let's take you through TFOS Dues II and kind of what is the understanding. And my goal here is to, if I were to ask you, how many of you have read the entire TFOS Dues II, Tear Film and Ocular Surface Dues II publication? All 270 some pages. Probably not many of you would say yes, including me. I was on the committee. I was on a subcommittee of a subcommittee, and then I had to proof one of the committees. So you would think if I did that much, I might as well have finished it. I still haven't read it, but I want to take it to the point where you see how practical it is. And the great thing about TFOS Dues II is they do have executive summaries, 5-page summaries, 50-page summaries. So they have made it very digestible, but I'm going to make it even more digestible. I'm going to save you reading 77 pages from the Diagnostic Methodology group by going through what we have tonight. So first of all, definition. It's a multifactorial disease. We do know that, whether it's environment, whether it's systemic medications, topical medications like glaucoma meds, whether it's surgical procedures, contact lens wear, hormonal related, gender related, all of these are, and there's many more, systemic diseases, et cetera, that contribute. It's a disease of the ocular surface where homeostasis, the ability to balance, is lost, resulting in symptoms, instability, hyperosmolarity, inflammation and damage, and neurosensory abnormalities play a key role. What's really cool about this definition is that they added neurosensory. Hyperosmolarity has always been there. It's the hallmark of dry eye. They added, the inflammation we've had for a while, but neurosensory was one of the additions, as was homeostasis. And I like the word homeostasis because it connotes the fact that we have a disease. So what we're going to focus on today are just a few things. If a patient presents into your office, to have dry eye, they have to be symptomatic and have signs. And that makes sense. I mean, think about the far right on this grid. If you had no signs, but tons of symptoms, we often call that pain without stain. That's also known as corneal neuralgia or neuropathic pain, neuropathic corneal pain. These are patients that have somatosensory damage. Their nerves have burrs, their nerves have, they branch into dendrites. They feel everything from temperature change to wind flow. It's a tough disease, but that's that side. The other extreme would be the person who has a lot of signs, like tons of corneal staining, even a persistent epithelial defect, but no symptoms. Thinking, what kind of disease is that? Well, of course, you probably know it's neurotrophic keratitis. If you had no signs and no symptoms, you have no disease. So dry eye is signs and symptoms. One of the great additions, I believe, to the TFOS Dues report was this part right here, where they talked about differentials. Being in a referral clinic for just advanced ocular surface disease, it's amazing to see a few things. Number one, how far the professions have advanced positively, meaning what I received today is far advanced from what I received 10 years ago. So we are continuing to advance. But a lot of times I'll have days where 10 referrals for dry eye, only 3 of them had dry eye. And you think, how's that possible? Well, there's a lot of differentials that seem like dry eye, that patients have dry symptoms, dryness, burning, foreign body, photophobia. And yet when you measure osmolarity and you look at tear breakup time or staining, you don't see a lot. So they include conditions like conjunctivochalasis that you see at the clock hour, 8 o'clock, epithelial basement membrane dystrophy at 10, 11, giant papillary conjunctivitis at 12 o'clock, Salzmann's nodular degeneration at 2 o'clock, medicamentosa and other issues, perhaps even stem cell related, at 5 o'clock. And really, if you look at the number of patients that have symptoms of dry eye but don't show a lot of signs, it's a huge list, from allergic conjunctivitis to infections like conjunctivitis, mucin Fishing syndrome, limbal stem cell deficiency, Demodex blepharitis is a big culprit. Even eye misalignment. You'd never think that a person who would come in saying my eyes are dry and they burn and they get worse when I'm on the computer. That sounds like dry eye to me. About 10 years ago, an optometrist from South Dakota called me up. He said, hey, Paul, I know you got this big dry eye clinic. I bet you have patients who have symptoms you can't resolve. And I said, yeah, I do. He said, and they might have even had mild signs. You got rid of the signs, but you can't get rid of the symptoms. I said, yeah, how'd you know? He goes, well, everybody has them. But I figured with your clinic, you probably have a fair number. I don't know if that's complimentary or not. It probably doesn't sound too complimentary. But nevertheless, he said, I'd love to fly down from South Dakota. I think I can fix them. And I thought, well, I mean, I'm always open to learning stuff. So sure, you want to fly yourself down? I'll pick you up at the airport. We'll go into the clinic. So he flies his own jet. I thought that was impressive. Into the first time I'd ever visited the private airport in Lexington, Kentucky. And I picked him up and driving him to the office thinking, gosh, what am I doing wrong? This guy's got it right. Flying himself in. Anyways, we lined up 10 patients. He asked for 12. Close enough. I got 10. 9 of them had eye misalignment, convergence insufficiency, exophoria. And I'm thinking, he didn't ask me to put in eye misalignment patients, I probably wouldn't have even known what to look for. He just asked me to find patients whose symptoms I couldn't resolve. And sure enough, 9 out of 10 just needed some prism. Today, he's invented a technology called NeuroLens that actually is way beyond just putting prism in lenses, that solves it for these patients. My point was, these are all conditions where they sound like dry eye, but they're not. Conjunctival chalacious, conch concretion, superior limbic keratoconjunctivitis, episcleritis, exposure keratopathy, and the list goes on. Here's a gentleman who came in my office. He said he spent the last 5 years seeing doctors, spent, as he knows, over $20,000 on scleral lenses and treatments and therapeutics. He said, although the scleral lenses were the only thing that kind of worked, he thought he'd try and get another opinion. He happened to be told to come over to the clinic. So I looked at his eye. Unfortunately, I happened to have some staining, probably because he wasn't wearing scleral lenses superiorly. So without that, I might have missed it. But his osmolarity was normal. And thank goodness for good imaging, like his in Haag-Streit technologies. I could see he had a good breakup time. He had ample tear meniscus. You could actually see the upper being very strong. Lower was just as strong. His expression was perfect, probably because he'd been treated by all these doctors. But nevertheless, that particular area superiorly made me think at around 10 o'clock, something's going on. I averted the upper eyelid, and sure enough, there was a concretion. I averted his other eye, he had 2 concretions. I removed them. He called me a week later saying, Dr. Karpecki, you're a miracle worker. I have no symptoms. Well, not really a miracle worker. I knew there had to be something else going on when all the testing showed he didn't have dry eye. And fortunately, we were able to find the reason for the dry, gritty, burning, foreign body sensation that was there. So let's get into this key component of TFOS Dues II. When you leave today, you should have a whole new way of diagnosing dry eye patients. And for those who are already doing a lot of this, it's just going to enhance your knowledge or validate what you're already doing. It's also going to save you 77 pages of reading. So maybe you can go watch something on Netflix or do something more enjoyable. So here we are going to go through this in the next 25 minutes. And then I'm going to have Mitchell take us through a little bit of why imaging is so important to this and why I tell doctors who are starting at really focusing on dry eye and other ocular surface disease clinics that the most important technology you purchase first is a good slit lamp imaging system. That's it. You're going to see why that's the case. So let's begin with diagnostic methodology. This is the overall summary that came out of hundreds of hours of research from our committee. This is the committee I was on. I wasn't chair, I was on the committee. I was chair of the symposia and the one that was canceled this fall in Italy. But the basic way of managing dry eye, according to these experts, in the sense that the people on the committee knew research inside and out. I know patients. I see 40, 50 patients a day, and I've been doing this for a long time. So I got a good clinical piece. But these docs, I mean, they knew the research and the studies, and they put it all together clinically. We came up with this algorithm. Number one, triaging questions. When you start out, the first thing you want to do, starting tomorrow in clinic, is have a list that your front office staff that takes calls has, or your staff doing history, or better yet, have them fill out this questionnaire before they show up so you can save time with them in this COVID-19 era. And they basically, if you look at all the questionnaires, there's 5 that I like. And this came from the OD Dry Eye Summit in Denver, Colorado in 2014. And I still use this today. Basically, it says, how do your eyes feel? How do they look? Like, are they red? How's the vision? Do you get fluctuating vision, for example? Do you have the urge to use, or are you using artificial tears? And how much time do you spend on digital devices? What a wonderful 5 simple, fast questions. If you get and those are all in that list, even though the list had other things like contact lens wear, previous refractive surgery or cataract surgery, etc. These are the ones that really stand out and make it easy. So grab a picture of that, use that in clinic. You'll be amazed at what that does for enhancing your practice. And then you've got to go ahead and take a look. And if they say their eyes are irritated, image capture is key. And I'm not exaggerating. In fact, a lot of times when you do a presentation, you try to talk about the technology. This was the other way around. I was talking to Garrett and I said, the most important piece of equipment any doctor can have if they're going to run a dry eye clinic is anterior segment imaging. It's just actually, and of course, Haag-Streit does all imaging with a slit lamp. It's slit lamp imaging because it allows you to save a good 5 minutes per patient in explaining what's going on. I'd rather show them a picture of their eye. I mean, I could always send them Rendia imagination videos as follow-up, and I get good success with that. But in the lane, I love being able to say, this is your eye. And you can tell there is a lot of irritation and redness there, and they comment on that. I show them a picture of expression. I might show them staining. It helps them to know what we're talking about. And then if I treat them and I get them to this level, I can feel pretty good about saying, here's where you are today. And it's amazing. I mean, I wish I could tell you every time a patient comes into my clinic, I remember what they were like the last time they came in. I'm sorry, I can't, but imaging can. So going back on my Haag-Streit imaging system, looking at what they had before, seeing that they've improved, that is, they went from that redness to this redness, that's very clear. And sometimes even the patient, because it was so gradual of an improvement, didn't even notice it. They knew they're better, but you look at that and they say, wow, I'm in the right place. I'm doing well. This is a really good sign. And even if their symptoms aren't there, they feel better leaving and their symptoms will catch up. Second, look at risk factors. You know, are they a smoker? Are they on antihistamines? Are they on antidepressants, contact lens wear, any of these risk factors that play a role? And in order to be dry eye, we showed you this slide at the beginning, you have to have symptoms and you have to have signs. So rather than take a lot of time to have symptoms, I guess you can have your technician read the questions of a DEQ5. There's only 5 questions. But I like having them do a speed questionnaire ahead of time. It gives me a number. I know what it is, and I can compare that number to later and see if they're improving. And they can do it online before they come in, which is very COVID positive in the sense that you're not doing things right in front of the patient. You're limiting contact and you're limiting time with them. So then we get into diagnostic tests. And a lot of people think that in TFOS Dues II, we had all these complex tests you've got to do. And we looked at every test, but we actually said you need to do one. Well, you need to do one of 3. I'd recommend 2. You need to do a tear breakup time. So that's 1. Osmolarity, that'd be your 2, or ocular surface staining. Any one of those, any 2 out of those 3. So a lot of people say, Paul, I know you're a real big believer in osmolarity. And I am. I couldn't imagine practicing without having this device. I mean, I can't tell you how many times I have a patient who comes in and they measure 285, 286. I say, you know what? Unless you put a drop in your eye 5 minutes before we did this test, you don't have dry eye. And they look at me and think, really? I said, yeah, this thing tells me you have a 2% chance of having dry eye. And sure enough, they don't. They have conjunctivitis or exposure keratopathy or allergic conjunctivitis or epithelial basement membrane dystrophy. That happens a lot where they have EBMD, but they don't have dry eye. Chris Starr did a paper that kind of showed how many times when you have normal osmolarity, it's not dry eye. And it was almost all the time. It was many of these different things, eye misalignment. So I do believe this is a great test. But really, the Haag-Streit imaging system has everything you would need from the TFOS Dues II recommendation, because you could just do your tear breakup time on here, and you could do your ocular surface staining, and you can capture it. So now you've got signs, 2 of them, you've got symptoms, predisposing factors, risk factors. You pretty much know what they've got, and then you can move forward. Mitchell, I'm going to have you take us through the Haag-Streit imaging system because it has so much capability. In fact, way beyond even probably the ability that I would know. And this is, you know, where it becomes so valuable from a patient education, from maximizing your imaging, being able to show more than just ocular surface disease, but Fuchs and all kinds of other conditions. So I'm going to hand it over to you to take us through how this Haag-Streit imaging can contribute to our success.
I'm going to let you continue to drive instead of swapping screens here. So like Dr. Karpecki was saying, you know, the great thing about having a slit lamp and imaging added to it is really patient education. Without it, you know, I just simply don't know how a patient can understand exactly what you're looking at and how you can describe it without an actual image. This right here is just really a diagram showing you, you know, what you can see with a Haag-Streit slit lamp. And it's kind of just showing you, for the most part, how the light comes down from the light source, which is all LED, to the optics, which is on the, obviously the doctor's side, and back to the patient, all functioning throughout the slit lamp here. If we want to move to the next slide. So pretty much right here, just the image, you know, right here on the cornea and the lens, and it's pretty much bringing out the light and showing you something that you wouldn't normally see if you were just looking through a slit lamp with no light. We can go on to the next one. Once again, another play. With our slit lamps, you can adjust light in so many ways. So this would be just looking at a glass in a room with light on, like your standard overhead light on. But if you turn out that light and turn on a slit beam or use our background illuminator, you can actually see the details of the glass that you wouldn't normally see with just looking at it on a glass on a table. We can move next. So here, if you were to open up where we adjust our slit length, we have a couple different settings here where you can, go through each step, and as you can see, it opens up the slit or the light or the intensity, or you can gradually do it here on the left-hand side where we go from a single millimeter all the way up to 14 millimeters slit length. Okay, so with Haag-Streit slit lamps, we have two versions of, if you want to say converging optics or parallel optics, or technically speaking, Kepler style and Galilean style microscope. Our BQ and BP, which have a beam splitter and built like an additional accessory for imaging, has our converging optics Galilean. When you look at our BI 900, which is our newest model, and BM 900, which a lot of doctors are familiar with, they are parallel, so Kepler. We want to move on to the next. This is our range of slit lamps. Right here in this image, we're specifically showing the 4 slit lamps that currently allow for our imaging capabilities. Our BI is more our kind of starter slit lamp, 2 magnifications, 10 and 16. Has a, if you see my mouse, I'm not really sure, there's a camera off to the left-hand side, off the left ocular. If you step up to our next level, which is our BP 900, 3 magnification, 10, 16, and 25. This is a great option, middle of the ground, middle of the road slit lamp. It gives you that additional magnification 25 times, so you can really get in on the eye, get more details as well. And then our next step up is our BQ 900, 5 magnification, starts at 6, 10, 16, 25, and then 40. The biggest difference between the BP and the BQ in their imaging modules, if you're familiar at doing standard photography, on the BQ with the IM900, we have an additional knob here where the beam splitter is, and it's actually your aperture setting. So you can actually, the other term for it is your f-stop. So like 1 through 6 steps in your f-stop or aperture setting to allow more light between the examiner and the patient, or less light if you need to dial it back. And then our 5th or 4th and final option, if you're looking to blow up a lot of images, do scientific posters, this is modeled after the BQ but has an external flash and external camera back. As you can see, it'll go up to about 22, 25 megapixels. So if you're looking to do, like I said, posters or display it on a rather large screen projector, you'll find these in major research facilities, major medical centers. If we want to move on, we have switched everything from our tungsten bulb to LED. We find it to be, a little bit more illuminating, more real of an image, softer light for the patient too. You don't have to crank up the rheostat to get a really bright light anymore. Also, it's very green, very environmental friendly. Here's a little more detail as to what it looks like. As you can see, the LED illumination really clears up everything. Also, with all of our imaging, you get an additional light source, a background illuminator, that'll allow for additional light to cover the surface of the eye. Our 4 capturing, obviously you could do a still image or also a 5-minute video. So if you're trying to show a video, teach educate. The 5-minute video is great. The other thing I really like to do with the video is if you do plan on doing any gonio, or use your 90 diopter lens or digital wide field lens and you're trying to get a view of the retina, I still think the video clip's the best way to go. Additionally, if we want to move on, I'll kind of get into each of these a little more. In order to trigger or take an image off of our slit lamp, we have added this additional capture module, release module, or they say, instead of turning on your slit lamp, there's a on-off button. You just tap it once, it turns it off. And then we also have a sensor underneath the slit lamp that will determine right or left eye, OD or OS.
There we go.
These are your control or your rheostats. The front one controls your slit beam power, and the back one controls your LED light source background illuminator. The background illuminator actually also has a blue filter built in as well, so you can turn the knob up top on the tower and actually turn the blue filter on as well. Okay. Moving on, so this also, these two little buttons above the big capture button. So the big silver kind of space bar looking button is where you would actually capture the image. The two above it increase and decrease exposure, but they're also used in our history trigger mode, which is, I call the blink effect, or, you know, a twitch effect. So if the patient moves and you thought you were going to grab a great image, our history trigger actually allows you to take a 30 frame burst. With these two buttons, you can actually rewind, fast forward within that 30 frame burst. And once you find the best image that you took within that 30 frame capture mode, you then hit the capture button again and it'll extract the best image. Once again, just kind of putting all the light together. You know, if you're looking at the cornea, looking for a cataract, here it is again, just using the different modes of light coming out of the slit lamp. This is, again, another kind of to show you the history trigger. It's not showing you 30 frames, but it does take a multi-frame burst. And once again, you can extract that best image in case there is some type of patient movement, even doctor movement, and you're like, oh shoot, I wish I would have had gone back 10 seconds ago to grab that better image than what actually appeared on the screen. Well, here's your option. It's called the mistake history trigger. So if you need to go back and get that one where the patient moved or right before they moved, here's your option to do that. I believe at the moment we're the only people that will allow you to do that. Contrast enhanced filter. Here's your yellow enhancement filter. Here's your yellow filter. The BI actually has it built in to the slit lamp itself. Our other slit lamps, the BP, BQ, and BX, would need an additional accessory, but we do offer the yellow filter for all of our slit lamps. Here it is. Just another look at it. This is what you would order if you wanted to add in the yellow filter. I'm sure Dr. Karpecki will go more into talking about, you know, adding fluorescein, taking images with the yellow filter, especially with dry eye is the case.
And that's where it takes me to. You're exactly right, Mitchell. So here's just an example of what Mitchell described so eloquently of how you really can enhance what you're seeing, the image capabilities. And it's fascinating how many times I'll look at a patient and in the regular blue without the filter, and it's hard to tell they're staining. You put the filter in and it's unmistakable. In fact, you're shocked by how much staining actually exists. In fact, one of the areas that I've really streamlined clinical practice, prior to COVID, we were seeing over 60 patients a day, and I'm the only doctor in clinic. Well, I have some residents and, you know, externs sometimes, but even that can slow you down a little. And so I'm just the only doc, but I have a really good team, obviously, around me. But what we discovered that is if we could limit what we're doing, so we just do osmolarity, we just do staining, We just do the symptom questionnaire ahead of time and we express the oil glands. We can get a pretty good idea of where they're at. My biography is done ahead. So we were able to get all this information, and I could go through a lot more patients, especially with imaging capability, because I could explain to the patient what's going on. Very quickly, they get it. They know it's their eyes. They're responsive to it. They listen to me. In fact, I've had patients who've been asymptomatic, and I have, had case where Demodex was really prevalent. I said, "You're not having any problems?" The patient said, "No," and I haven't done anything about it. So what I do is I image where the Demodex is, the eyelids and the blepharitis. And I find if I make an image really big, I can really scare people. So I magnify it, and then I show them this, and I tell them, I'm seeing something here that concerns me. And whenever the doctor's concerned, the patient really looks at you closely. They go kind of a little white. They lean forward. It's fascinating to see the body language change when you use that phrase. And then I point out what's wrong, and I point out what will happen if we don't do anything about it. And what we've been amazed is that we get these asymptomatic patients because of the imaging to start doing something to prevent it from worsening or to treat it. And they would never have done that being asymptomatic prior to seeing their own eye and the image, even if I did have to blow it up a little. Breakup time is readily visible. Tear meniscus height, as you see on the bottom, is visible. All of these are critical to explaining what's going on. And I don't need a lot of time. If staining's the worst thing, I show them staining. If expression's the worst thing, I show them what came out of their meibomian glands. If it's breakup time, I show them what a breakup time is, how quickly this happened. If it's exposure or other diseases, I'm able to explain it. So let's go back to the TFOS Dues II. We had the patient come in because we had the right triaging questions. How do your eyes feel? How do they look? Fluctuating vision, urge to use tears, how much time on digital devices. So we had a good idea. Then once they presented, we looked at risk factors like contact lens wear, antihistamines, previous surgery, you name it, smoking, etc. Then we did a symptom questionnaire like the speed, and then we identified if they had dry eye. Remember, we did 2 out of 3. Breakup time, osmolarity, or staining. So if you just had the Haag-Streit imaging system, it would be staining and breakup time. And that's it. You've got everything you need. Now, if there is a problem with breakup time and staining and osmolarity, is that it doesn't subtype. It just tells you have dry eye. It doesn't say the type of dry eye. We just know they have it. They had the symptoms. They had the signs. It's dry eye. Why is it so important to know what type of dry eye it is? Well, that goes into treatment. If you're treating evaporative dry eye, it's very different than treating an aqueous deficient dry eye. So the subtype classification was the next step. So this is pretty straightforward. We already looked at the Haag-Streit imaging. We enhanced our staining. And I was talking about how we created efficiency. Another way of creating efficiency is that filter. I don't now use lissamine green. I used to put fluorescein stain in and look at the cornea, and lissamine stain and look at the conjunctiva. I put fluorescein in. If I have the filter that excites the image, that I could see the staining. I see conjunctival staining with fluorescein just as easy. So I don't really need to put another dye in. I have it all right there. So that was ocular surface staining. And that was tear breakup time. And if you had osmolarity, you've got the trifecta, but really you have to have 1 or 2 of those. Now I'm trying to subtype. So my only 2 type choices are evaporative or aqueous deficient. Aqueous deficient, as you know, would be like Sjogren's or KCS. Evaporative would be meibomian gland disease related, meibomian gland dysfunction related, where you have a lipid deficiency. So the question is, okay, using my imaging system, which is pretty much doing everything I need now, how do I determine if it's evaporative versus aqueous deficient? So think about what your answer would be. Well, the best way to be able to tell if it's evaporative, in my opinion, is to express the oil glands. Get a Mastrota paddle like this from OcuSoft or any paddle. There's all kinds of them out there. Use your fingers, whatever you'd like, but you got to see what's coming out of the oil glands. And the most important area to look at expression is in the lower eyelid, because the majority of oils come from there. Plus, it's easier and it doesn't hurt when you do this without anesthetic. So lower eyelid is really the place to be. And then you press between the center and nasal. You can tell I'm fairly nasal there. Any 5 glands between nasal and central are really what you want to be looking at. Temporal glands on humans, according to studies by Don Korb, don't tend to work very well. So nasal to central. What would look good and what would be normal, which you don't have here, would be like olive oil. And you can barely tell it comes out. It just flows right out. If it was what we call, and that's called grade 3 out of 3, olive oil. 0 is no expression. So what's 2? 2 would be this, gel-like. Sometimes it can be turbid, but usually gel-like. Grade 1 is paste-like, like toothpaste, and 0 means no expression, 0 expression. Now, 0 out of 1 gland doesn't mean anything. Could have been a gland that was perfect, that just released and hasn't refilled. But if 5 glands don't produce anything and you get a 0 5 times in a row, that's much more serious. So expression is the critical sign to determining evaporative dry eye. And there's a great image. You can show the patient what's going on. They're going to get it right away. What's the best thing to look at to determine if it's aqueous deficient dry eye, the other form? So this, again, evaporative dry eye, you're seeing grade 2 to 3 expression, or 2 to 1, sorry, expression. I think the best way is to look at not staining. Staining was global. Yes, this patient has staining and it's pretty bad. But the little, what? Tear meniscus. That little tear meniscus is the key. And a lot of times when I do these lectures on dry eye, people will ask, well, what's normal? Well, according to TFOS Dues II, it's 0.02 millimeters. But you know what? I have no idea what that is. But I do know what's abnormal. I had the best example of this. There was a lady, a nurse, who received the Medal of Honor, Congressional Medal of Honor, or the President's Medal of Honor, one of the highest awards you can be given in the United States. And what was interesting is that she was a neonatal nurse. And the story said that she had probably saved anywhere from 500 to 1,000 babies or more. And because she eventually became the supervisor of this very high and intense ICU for infants and premature children, primarily born early, etc. And she rose up to the ranks. And they told us one example, and it was such a high level ICU that every child had their own nurse, their own RN, 1-to-1. That's pretty intense. Well, she was the supervisor. One time she came in, and again, 1-to-1 nurse to the baby. She looked at this one baby and said, oh my goodness. Went over there, opened up the incubator, picked up the baby, turned the baby around, saw the back was mottled, looked at the foot, there was crystallization where they had drawn blood, said, goodness, this is obviously sepsis. Let's get this child into IV stat, treatment. And what's amazing is that in a child that young, 24 weeks, 25 weeks, whatever it might be, having sepsis, they don't have a lot of time, maybe 30 minutes, an hour, I don't know, but not long. But there were examples like that where she saved their lives. And they asked her, how did you do this? Because this child had its own nurse watching her. And the nurse said, child was breathing properly. The vitals were perfect. The child was eating, wasn't crying too much or too little. Everything looked fine. And so they said, how did you know something was wrong? And she gave the best answer. She said, I just know what normal looks like. I thought, what a fantastic answer. That's what it is in clinic many times. Like, I know that's not normal. That's not a good tear meniscus. I don't know I have an idea what normal is because I've looked at it so many times and I don't measure it, but I use imaging to be able to tell what's going on. Saves time, it's efficient, and I know what's not normal. So this is an aqueous deficient dry eye. So guess what? You just saved 77 pages of reading. Triaging questions, I like the 5 from the Dry Summit. Predisposing factors, a questionnaire to gauge symptomatology, one type of sign, but I like the fact that with the imaging system, like here from Haag-Streit, you could do breakup easily and ocular surface staining. And because of their filter, you can do corneal and conjunctival with just fluorescein. So technically you got 3 right there. Then I subtype it by expression versus tear meniscus. That's 77 pages. And you know what? It works. And now if you know if it's evaporative, sometimes it's mixed, you know what to do. And why is this so important? Because dry eye is progressive. This is a disease that continues to advance. And if you don't treat it, it just continues. This was a great example. This was the original cyclosporin trial by Allergan. And they had a really good vehicle. I mean, in fact, the vehicle was so good, it was considered one of the best artificial tears ever. So if you used artificial tears rather than therapeutics and didn't make the diagnosis, in 6 months, the patients with dry eye had 39%, almost 40% increase in inflammation. And it's inflammation that causes damage and persistent and chronic damage. So this is why we need to do good imaging and pick up on this disease and use these algorithms to work really well. So, we really took some time, and we have some time here for questions, to simplify what TFOS Dues II diagnostic methodology really means to clinical practice. It is the most common condition we're going to face, whether you're an ophthalmologist or optometrist. It's TFOS Dues II is clinically practical. People thought, with Dues I, there was a lot of science, and they thought, how practical would it be for me to read this? This is incredibly practical. This is what I've been doing in my clinic for the last 6 or 7 years before this even came out. And it works. It's a great algorithm. It's very effective. But now there's a lot of science behind it. And all the people in the committee put their backing behind it. So they came up with ideas that were even better. So it enhanced what I was doing. Haag-Streit imaging system achieves practically all of what's necessary to utilize the TFOS Dues II diagnostic algorithm in diagnosing dry eye. And because it's a progressive disease, it really warrants having that ability to see things you can't see with any other imaging system, accurate diagnosis, and appropriate patient management. So with that, I think we can open it up for any questions for myself, for Mitchell. We really want to try and do this presentation in about 45 minutes, and we're exactly at, that was weird, right at 40, well, 46 minutes. We're 1 minute over, so we can open it up for Q&A now. Any questions you might have, or Lauren, anything in the chat line that may have come up that we can answer? Yeah, feel free to type in. This is a Zoom webinar, so you can type into the chat area any questions you might have.
I have a quick question. Do you, when you're doing your exam now with COVID and everything, and you obviously have imaging on your slit lamp, are you finding yourself looking at the screen and backing away from the optics anymore or less than you have in the past?
Yes, you know, that's a great point, Mitchell. You have the capability here. If you're worried about, you know, remember the two biggest risks to COVID-19 are time with someone who could, doesn't have, in our case, patient, but time with someone who could be infected, and duration. So the goal is for them to do a lot of the stuff ahead of time, and for you just to do the main things. And that's what today was about too, that you can get away with just one dye. You can, if you have a good imaging system, you'll see corneal and conjunctival staining like with the Haag-Streit imaging. You'll be able to get your assessment, educate the patient. And to your question, I have found that. I find a lot of times now, even when I'm doing expression, I could either press a button to get it and be done quicker, or I can even look when I'm looking at the eye, the staining at the screen. So now I'm a good number of feet behind the patient. And of course I have my plastic shield, but I've got, you know, the distance now, and I'm looking at it on the screen. I'm having the patient look straight ahead, and I've got it there. And then I could move further back and show them what's going on. So I think there's huge advantages to having imaging that goes even beyond what we talked about today is so critical to dry eye, is the #1 technology you should have if you're building a dry eye clinic. But now into what you mentioned, Mitchell, the whole area of COVID-19, allowing for distancing, less time with patients, and getting the response back. And you said something in the beginning that was so accurate. Patients who you don't have an image to show you are lost. They can't orient what you're trying to explain. You're saying, okay, the front of the eye, it's a clear window, has these dry patches and staining. They're lost. You pick up an image, show them it, tell them, here's what I'm looking at. This is the clear window on the front of the eye. You're not supposed to have any green. Those are dry eye patches. Look at all that we're seeing here. Look how thin your tear meniscus is. It should actually go up 3 times that size. Look at what we got when we pressed on your oil glands. That should be olive oil. End of story. I mean, my 10-minute explanation is now 2 minutes. And then I could talk about what we're going to do, pass it over to my staff, go in and see the next patient. People wonder, you know, how we could see 60 to 70 advanced dry eye patients. Everything's referred in, so it's not like a quick post-op. This is how. This is capability, whether you're looking at the screen to image, whether you're looking at the eye or just using it for education. That's how you increase efficiency. Okay. I have a question too for you, Mitchell. When doctors first incorporate this technology, like
Lauren's checking, or
yeah, I think she is, like Haag-Streit imaging. What are some of the key insights you provide right at the beginning? Meaning, you know, this is the most valuable thing you should do or know. Meaning, when you went from, let's say, a Haag-Streit non-imaging system, or even another technology that didn't have, let's use that, another technology, and here you now have the optimum, the top imaging capabilities between the LED and all of this. What do you have to guide them in as far as education to be able to make that transition? Because you definitely are stepping up with this technology.
I mean, we definitely have imaging guides We've created videos of, you know, how to use our slit lamps, utilize them a lot better, especially with the addition of imaging. I think we're up to like 6 videos now. They're all available on LinkedIn, I believe on our website. You know, it's really ultimately comes down to the lighting. I also, you know, we do quite a bit of hands-on now, get more and more doctors involved like yourself. And we kind of play off of each other as in ways to better, you know, capture the images. I think there's a few things that doctors aren't aware that, you know, we do have built into our slit lamps, we have a star fixation that the patients don't see, but you can actually use as a doctor to fixate on a certain portion of the eye, especially when you're using your 90 diopter, 78 diopter lens and actually looking at the retina. Also, the decentering knob on our slit lamp will allow you to do a scatter, and I don't think people actually realize that that knob's even there. So the more we interact with you at, unfortunately, no trade shows this year, but at trade shows, we actually get to show you these types of things that actually put us above everybody else.
Maybe we could do one virtually. I got a great question from Dr. Greg Schultz, a good friend of mine and a great clinician. And obviously from his question, he is obviously a good clinician because his question says, I've tried everything. And he's got it, you know, the real things you'd want to use from lubricants, topical steroids, oral doxycycline, amniotic membrane, punctal occlusion, LipiFlow, thermal pulsation. They still maintain SPK that I would consider significant. Even though they tell me they're 80% improved, what do you do to help these severe cases heal? Well, first thing, Greg, and you probably know this, but I'm going to answer it for the whole group, is to consider neurotrophic keratitis. So get your dental, you know, the best thing, some people use cotton wisp, that works too. I love dental floss, you know, and you don't want the minty or cinnamon kind, just that old fashioned acrylic where you go to Target or now online and you can get it like 3 for $1. And what you end up doing is you take the little, just break a piece off. You've got a filament. It's acrylic. It's just what's in like a Cochet Bonnet or one of these research anesthesiometers that why would anybody really have those? So you've got your dental floss, and you simply, you know, touch the cornea, not in the center because that tends to be symptomatic, and not at the limbus, but you know, in the middle, in the lower cornea. And oftentimes I'm amazed at how much downregulation of the nerves, early neurotrophic keratitis is there. And that's why they're feeling good. They're saying, you know what, I feel pretty good, but the signs haven't gone away because they're still somewhat neurotrophic. And then in those cases, yes, autologous serum has nerve growth factors. Amniotic membrane, which you already tried, has some, but then you might consider, you know, oxervate from Dompé. You know, that could be a really good option for these patients. To kind of help those nerves to get to where they need to be, and they'll get there a lot quicker. So I would rule out neurotrophic keratitis first. Next options, if it's not NK and they have good corneal sensitivity in both eyes, then you're really looking at biologics. So in this case, you've got one of them with amniotic membrane. I'd probably lean towards a cryopreserved form, but you can do, you know, that as an option. And I would add in autologous serum. You know, Vital Tears is an organization that's available almost in every city now, where they draw the blood from wherever the patient's at and they process it. It's a pretty good organization, very reasonable. And that allows us to now, because used to be, I used to say autologous serum and people say, well, how am I ever going to get that? Well, apparently they're in almost all the major centers now, or cities, I should say now. So you've got that option. And then next to it, above that would be like scleral lenses or some sort of, you know, cover that way to get there. But yeah, rule out NK first, Greg. I'm sure you have it. I think that's really the path that I'd be looking at as a primary. And if that all doesn't line up, then look for lid apposition issues. You know, they don't have a good tight lid seal. They have some early floppy eyelid syndrome, lid laxity. It's amazing how often does that. And then if that's ruled out, there's probably a systemic disease there that just hasn't been diagnosed. It'll come out in the future. Would autologous tears make a difference? Yes, they would make the difference. I do believe in that a lot. I think it's got a lot of good growth factors in it. It's the patient's own. I would probably do a 20% for this patient. You could do 30 perhaps. I wouldn't do more than that because often you have to dictate the percentage you want. All right, Joe Stam, great friend of mine too. It's all my friends are writing in. Thank you. Joe's on faculty up in University of up at Boston, the optometry school. So this one's for you, Mitchell. What is the biggest mistake that doctors make when attempting to get a quality image of the anterior segment? And Joe teaches a lot of students, so this will be really valuable for all of us, but especially for professors like Dr. Stam.
You know, the biggest thing that I see doctors kind of forget that they have is the diffuser. So hanging below the mirror is a plastic piece that you flip up to diffuse the light. And we tend to find that, you know, a lot of times those are either not there or people just simply forget that it's there, and they forget to flip it up. And what they're doing is they're just letting too much light in. So it's washing out what they're really trying to get an image of. So that's usually what we tend to run into quite a bit. Hopefully that helps.
That does. And from a dry eye standpoint to that question, I know you know this, Joe, too, but it's a good reminder for everybody if you're putting fluorescein in, you know, not too much, not too little is critical. That does take a little bit of practice. But then, you know, if you put the right amount, it still takes a minute to 2 minutes for everything to equilibrate. So I often, while I put the dye in, I might do debridement of the eyelid. I might, you know, do the expression or some other things in between that I'm imaging. And then at the end of that minute or goes by, or 2 minutes, or I go to my EHR for a minute or two and finish up, then I can do my slit lamp with the filter. That's so valuable to have. It's, as I said earlier, it's remarkable to look at a cornea without the filter and then slip it in and think, wow, I would never have seen any of this. And all this staining, especially the conjunctival staining, shows up. That's where it's real difficult to see it. And so you can get away with one. But that amount and that length of time with the dye to equilibrate with the tears and to more or less react with the cornea is also critical. That's not, you know, which plays a key role in imaging when it comes to dry eye. But I think what Mitchell said is true. The diffuser is so valuable. You're looking at blepharitis, you're looking at the eyelid, that beam of light's just too strong. Diffusing that across gives you incredible optics and imaging to where you can see individual collarettes and explain to the patient exactly what's going on. Sequential installation, Dr. Stam brought up, gives you an even greater impact or a result, and that is true. It is fantastic with the second application, so you're not getting a lot. That second one, do something in between, can also get you there. That's great insight. All right. Yes, the lecture is being recorded. Had a question on that, be provided for all of you. And I think we're like within a minute or two of our time point. So, you know, certainly, Mitchell, I want to thank you for all your expertise and insights. That really helps, especially a talk like this, where although it's focused on dry eye, it's also focused on the importance of imaging. And that was what's great about the questions. We had dry eye questions and we had imaging questions and went back and forth. And I think that's really what I'd hoped to achieve this evening. I want to thank all of you for being on the call. We had a great number, but more importantly, you know, there's just so much going on, and we're still in the COVID era. Some places are increasing. So making time says a lot about you to continue to advance. It says a lot about the, you know, the future of our professions. It's really great to see that. I thank you all for the time tonight. Hope that you and your families are all safe, and appreciate you being part of this.
Thank you. Thank you, Dr. Karpecki. Everybody be safe. Thank you.
And thanks to Haag-Streit for putting this on. Really says a lot about them as a company. Not only have great technology, but just your dedication, and that's greatly appreciated.
Thanks. Thank you. All right, everybody have a great night.